Network. The Healthy Aging Committee was established about a year ago to provide educational programs to help us all live healthier lives as we live longer. For all of those who are already older, a main priority is to continue to maintain function and quality of life until the end. This requires that we manage our health conditions, that we manage our chronic health problems, that we maintain productive communications with our healthcare providers and with our family, and also that we understand how much our environment contributes to our well-being. Today's webinar will focus on steps that can be taken to improve both our health and our environment as our needs change. And we know that in life, everything changes. In all of our different moments in our life's course, we have to make adaptations and changes. We're very grateful for the excellent team of presenters from Johns Hopkins University School of Nursing for sharing with us what they have learned from years of research with a capable model. But before I introduce them, I would like to say a few words about the technical issues that you need to know about the webinar. We will be together for 1.5 hours. Each of our speakers has great information to share, so please stay until the end. You'll like it. Thanks to partnership with PAHO Aging and Health Program, we have simultaneous translation in English and Spanish. To select the language you want to hear, find the globe icon at the bottom of the screen with the words translation. Click on this feature and select your language. Para acceder a la sala de su interés, hagan clic en el botón.
So you can click on the interpretation icon on the bottom of your screen. It is a small icon shaped like a globe, and there you can choose the language of your choice.
So in a few days, it will be available in the websites of FSM and PAHO, as well as in the PAHO's YouTube channel. You will find the link to all of this information in the chat. The recording will be available in both languages. We want to make this webinar useful to you, so we have allowed a good amount of time at the end of the session for questions. Please use the QA function to write your questions. Use the chat function to send messages to each other and just simply general comments to the audience. So we're ready to start, and we again thank everyone who has agreed to be here today, and we hope to share a very, very good hour and a half. And thank you, Gloria, President of FSM, for your support for healthy aging. So the speakers today are Melissa Decardi-Ladek. She's an assistant professor. Dr. Ladek is an assistant professor at Johns Hopkins University School of Nursing, a researcher, clinician, and her focus is on how stress, self-efficacy, social cultural factors influence the biology of aging, chronic disease, and frailty. Our next presenter after Melissa will be Tiffany Reiser, who is a research assistant at the Johns Hopkins School of Nursing. She has extensive experience in providing home care in rural and urban communities. So her research focuses on the implementation of home care interventions within healthcare systems to promote aging in place. And third presenter will be Sabrina Elias. She's a research coordinator also at the Johns Hopkins School of Nursing. but she has an interesting background for all of us because she um, has a Bachelor and Master's of Science in Nursing from the University of Sao Paulo. Sabrina is a public health nurse, researcher, and also former international consultant for the Pan American Health Organization, WHO. She has extensive experience working with countries in Latin America and the Caribbean. So welcome, Sabrina, back to the PAHO family. So we begin with Melissa, and we're so grateful for not only your time, but for putting together this great team. Can't wait to learn from all of you today. So the platform is yours.
Thank you so much, Martha, and buenos dias. And we're so excited to be here with you today. Thank you for hosting us. So these are topics that are very near and dear to, I know, all of our hearts. And how can we help people age well in their homes? So we're going to start with, we have no disclosures. We're going to start with the capable program. So we're talking about aging at home using this capable program that was developed by Dean Sarah Zanton. She's the Dean of the School of Nursing at Johns Hopkins University, as well as Dean Laura Gitlin, who is the Dean at Drexel University for their Nursing and Health Professions School. So two really amazing women who came to decide that this was an important problem. So Dr. Zanton was visiting people in their homes. She would go to people's homes that were functionally limited, that couldn't get out of their homes well, in order to see them and give them medical care. And we're just going to talk briefly about Mrs. B. So Mrs. B is an older woman with 5 chronic diseases. She has trouble getting in and out of her home. And one of the problems that we saw is her floor. Her floor had missing pieces in the floor. And the problem when you can't see very well and when you can't walk very well is that having problems with your floor means you could trip and fall very easily. These are already patched, you can see, but there were some problems with her floor. Her steps were also falling. The carpeting over the steps was ripped and also created this, and the vegetation was overgrown, and it's created again a big fall hazard. So for Dr. Zanton, it became so clear that taking care of her was more than just about her diabetes and her high blood pressure, that if she couldn't just treat just those diseases, instead she really had to treat the whole person, and that whole person included the environment. And that was the best fit. That was the way that we could probably really help Mrs. B, is by making sure her floor was safe, her steps were safe. So that was kind of part of the way that Capable was born. Now, I just want to mention too, in healthcare, we tend to focus on the diseases, again, the diabetes, the arthritis. But, when you think about function, how someone moves, how they walk, how they're able to take care of themselves and do dishes and cook. These are very expensive in the healthcare system in the US and in basically every other country. You'll see here that as people get more diseases, the cost, which is the orange number, goes up within the healthcare system and also within the out-of-pocket expenses, the expenses the family needs to pay. It gets really, really expensive. And in the last column, you'll see there that very large number of $21,000 with high need people that have functional limitations. They can't walk as well, and they can't, take care of themselves as well. Now, this is the interesting thing, is those expenses drive all of healthcare spending, right? This is the lion's share of how much money we spend in healthcare. And I think that, I can't say for sure, but I think that this is true in many countries, not just the US, that as people become more functionally limited, they cost more to the healthcare system, and that drives the overall spending in our healthcare systems. This is a big, expensive problem, and every country is getting older, right? Our average age continues to go up. So the key aspects of Capable are that this was a 4-month program where you had a handy worker, you had a nurse, and an occupational therapist. And let me just stop there. You heard me correctly. I said handy worker. So a handy worker, a handyman, was a part of the healthcare team. And that's revolutionary in and of itself, right? When you think about healthcare, we think about pills, we think about shots, right? We think about blood pressure. What Capable did was it expanded the idea of who is part of the healthcare team and how we do healthcare, right? So the main outcomes that this study was looking at were function. They were looking at activities of daily living, which is, am I able to bathe myself? Am I able to go to the bathroom by myself? Am I able to cook? Can I put my clothes on? Can I walk? Things like that. And then also this instrumental activities of daily living, like, can I cook for myself? Can I do my laundry? Can I pay my bills? These are really important things to people. As we all get older, we want to be able to do all these things for ourselves for as long as we possibly can, right? So here was the budgets. The nurse came a few times throughout the 4 months. The occupational therapist came. The occupational therapist worked with the participant as far as how their environment was affecting the way they were functioning. And then the occupational therapist would give direction to the handy worker about what to do in the home to make it function well. This is my favorite slide. This is my favorite slide because it wasn't just about the coolness of the handy worker. It wasn't just about the occupational therapist and the nurse. All of this was patient directed. And I believe that this is part of the secret sauce of why Capable worked. It was all about the patient's own goals, the participant's own goals. And so if Mrs. B, if her goal was, I just want to be able to wash my own hair in my own bathroom, if that was her goal, then everyone, the occupational therapist, the nurse, the handy worker, all worked to make that bathroom safe, to put the handrails up that needed to be up, to do strength training so that she could actually, use her arms to wash her hair. And the nurse would reconcile all the medications to make sure she wasn't getting dizzy from the medication she was taking so that she could take a shower and wash her hair. Everything revolved around the goal of the patient. And I think that that is, again, what empowered the older adults to feel like, wow, this is all about me. This is all about what I want. And ultimately, all of their healthcare outcomes improved too, right? So I think that as we think about the ways we approach ourselves and other people, helping people almost, understand their own goals, their own values is a very important key to aging at home, and trying to make those values be the keys of how we even do our own healthcare, and how we approach that is, I think, the absolute key to this. So let's talk about Mrs. R. She wants to be able to prepare her meals without shortness of breath. She has some heart failure and she has a lot of arthritis, especially in her back. So she can't stand for very long. what can she do? She wants to still cook for herself. She wants to stay independent, right? How do we help her? So the handy worker lowers some of her kitchen cabinets so that she can get to them easy, so that she can get to everything she needs. We get her a reacher that's circled there so she can grab the things that she needs. This is not expensive, a reacher. The handy worker puts a mirror. This is, who knew that this was even an option? But there are these mirrors you can install above the stove, and people can sit and still see what they're doing. This is really incredible. Who knew this even existed? But it's something that's there. And now she's able to prepare her meals much more easily without that shortness of breath and pain. She feels like she can still take care of herself. And in the grand scheme, this wasn't that expensive in the grand scheme in order for her to maintain her independence and meet her goals, right? So here's another example. These are on the left here on this before picture. You see stairs, but there's no rails. When you're an older adult with a lot of arthritis or trouble seeing, you need those handrails. This is not that expensive, right? At the end of the day, to put handrails up. So handrails were put up that are safe, that are sturdy, and now this person can get up and down their stairs in a way that they weren't able to do before. It was so unsafe before. So some of the outcomes of Capable, right? It's all well and good, but this was kind of expensive too for a program that didn't have pills. Now remember, pills are very expensive over the life of a person. We're talking about one time doing this intervention. The activities of daily living, those activities of kind of getting ready in the morning and being able to take a shower improved most of the time. That's that 74% number, 74% improvement, 65% improvement in those instrumental activities, like I can cook for myself, I can go shopping, things like that. Other things that weren't primary outcomes of the study, but we saw great improvements are depressive symptoms. People were less depressed by a lot, 52%, 53% improvement in depressive symptoms because people were feeling empowered to care for themselves and they felt like people were listening to their own values and goals. Home hazards were huge improvements in home hazards. The homes became much safer and therefore people could stay there longer, right? So the next couple slides are a little bit more randomized controlled trial slides. I know that some of you can read these with no problem, and some of you, this is not as important, but all of this data basically shows that there were great improvements in the activities of daily living and instrumental activities of daily living, even compared to the control group that was having someone talk with them. And here is, again, the percent reduction in these ADLs and IADLs, those activities of daily living. This is one of the main indicators that as researchers we use when we talk about disability. These are the measures we use when we talk about disability. And I'll tell you, it's really hard to change trajectories of disability. It's a hard thing to change. So the fact that this was showing a lot of changes, it was really impressive. Here's there's a few other randomized control trials. So this has been studied in a couple different settings, which is really important, right? With different teams, different settings in different areas of the United States. And in all cases, we still saw similar improvements in these disability outcomes, which is really excellent and exciting. And here's the big news, and I think this is big in any country, right? We already talked about those disability, as people have more chronic diseases and as people get more functionally limited, they cost the system more money, right? And yet Capable was able to decrease spending for Medicare, which is the main insurance for people over 65 here in the United States, by a lot. This is a lot more than the intervention costs. a lot more, right? This greater than $20,000 per person, right? This is after doing all the health economics. Part of how that was done, it was because people were able to stay at home longer. I'm sorry, I accidentally skipped around a little bit. So yes, so very much cost-effective intervention. And this is looking at 1,000 people in, this is for Medicaid, which is a different type of insurance for people that have lower incomes. People who had the capable arm, the cost overall for those 1,000 people was much less than the cost without that. And this is, I'm not going to go into all the acronyms. It's just another way that we looked at data to see how much capable could save money, right? And lastly, I think from a satisfaction perspective, people were very satisfied. I think, again, when we're able to elicit patients' goals and values, and then align our own intervention work, our work, with the person's own values and goals, that's always a great way to go. And I think even as an older adult, that is a great thing to lean into. What are my values and goals? What drives me? And how do I link that to my care, right? How do I communicate that to my providers? But also, how do I make that be the motivation behind the reason I do things in my life? So here are just a couple of other examples that are so inspiring, right? So Mrs. D had been stuck in her house for 2 years, right? This is unfortunate, right? We all know people who can't get out of their homes. She was confused, she was over-medicated, and part of what the nurse did, incapable, was do a reconciliation of medications and try to decrease medications or remove medications if someone was being overly medicated. It took her a long time to get to the bathroom. She sat on a commode all day as her chair. And Capable came in, they changed some of the medications, they worked with her healthcare team. She has chairs along the hall that she can sit at so that she can move in different areas of her home. There was railing put up. There was a chair at the top of her stairs. So again, she could take lots of breaks. Her bed was a little higher, so it's easier to get in and out of. And she had a wider commode put in. All of these things made her life so much better. And she was able to then move around and enjoy her life space better. Here's another case study, Mrs. H. She had many different health concerns. She could not breathe, and that was one of her main symptoms. And she couldn't walk very well. She couldn't do steps. She was able to, the nurse was able to help connect the participant with their PCP in order to get better inhalers so that she wasn't as breathless. She was able to switch some of her medicines, Aleve to Tylenol, because Tylenol is safer for her and be given her medicines. She did all these exercises with the occupational therapist to get stronger. She was able to take a bath because of the modifications they made in her home. She was having trouble hearing, and we were able to get her a super ear so she could hear better, and repaired her railings and her linoleum and her floor, which made her environment so much safer. And she's able to engage in her healthcare so much better. One participant said, if I had 10,000 tongues and they could all speak at the same time, I could not praise the Capable program enough. But so high praise indeed. In an effort of time, I think, yeah, we have plenty of time here. So I think the most important take homes about why Capable has been so successful is because of these principles, these basic principles. We were taking into account not just the person and their diseases, but we were also taking into account their environment, taking into account the safety of their environment and how they interacted with their environment given their functional limitations. We also, all of this was patient directed based on people's goals. And what that does is it unleashes motivation, right? People feel motivated because this is near and dear to their heart. And that's a really powerful tool to change behavior. We also honored people exactly where they were at. We just talked about the woman who took 30 minutes to get to the bathroom because she couldn't walk well. Okay, let's put chairs along the way so that you can get there safely. And let's just honor where you're at, right? And make your environment work for you where you're at. Also, we provided the resources to achieve those goals. And also what this does too, the other really important thing is all of a sudden someone realizes, I can do this. I think one of the most scariest things is a fall, right? I don't know if anybody here has fallen before, but if you've ever fallen, it's really scary to then get up and try to go again, right? And what Capable does is, wow, I'm able to get to the bathroom with all these chairs. What else can I do, right? It improves people's self-efficacy, their confidence in their own abilities to do things for themselves, right? Their own abilities in general. And that is really, really powerful, and it is changeable. It doesn't matter how old someone is. You can always improve your self-efficacy. I think what the take homes too with regard to function are that when someone has disability, it's very expensive. It's expensive for the family, right? Caring for the older adult. It's expensive for the system too, with more hospitalizations. But ultimately, I think sometimes in the healthcare system, we don't care as much about function because it's not diabetes, it's not high blood pressure. And so it gets lost sometimes. But this is what older adults care about. This is what all of us, I'm sure that this is near and dear to the hearts of many of you, is how am I moving? How am I able to work in my environment? This is paramount. This is the most important thing. And the coolest thing about Capable, the most exciting thing, is that it can be modified. Function can be modified if we do it right. And this is a great program that showed that. So now Capable is being implemented all over the United States. It's actually has 48 implementation sites since this slide was put together. There are many organizations that are now implementing Capable, and you can see some of the numbers around here as well. So the other thing that I wanted to just mention is, when you think about a great program that someone develops at a research institution, right? How do you get that to be, uptaked by different organizations all over a giant country, right? The United States is a giant country. Brazil, it's just like, how do you get buy-in, right, from your healthcare, the people that make decisions? I think that's why we do the studies we do. It's like, okay, well, now we see all this evidence, right? I think the other things that we've seen in our country that have helped is with older adults, there's a real movement to take into account what matters most to the older adult. And that has been a very big help to a program like Capable, because all of a sudden we care about the values of the older adult, and we realize too that the older adult maybe doesn't care at 80 years old, perhaps isn't as nervous about their 10-year stroke risk as much as they are about, am I going to fall today, right? So if we can actually listen to our older adults, our parents, our sisters and brothers, if we can listen to them and find out what matters to them, that can be helpful. I think also there's a shift in our country to that things outside of even the body affect the body, right? So whether it's how people are doing with their finances, with their homes, all of that is going to affect someone's health. I think the things that can keep it small in our country are sometimes how things get paid for. Since we don't have we have Medicare for older adults, which makes a big difference, but sometimes who pays for capable? If say you have an organization like Meals on Wheels that brings food to low-income older adults in their homes, and they want to do capable, if they pay for it, who benefits? It's actually the insurance companies, it's Medicare who benefits, or it's the state who benefits. So it's hard to find out, well, who should pay for capable and who benefits from capable. I think that's a tough thing sometimes in our country, the way that we do healthcare. So President Biden has even mentioned capable in a speech. So this has gotten a lot of really great press. And yeah, I think that the way that this really has done is we started with research and the idea. We got funding to test it. And then philanthropy is what helped it get bigger, is big organizations like the Hillman Foundation and the John A. Hartford Foundation here in the United States. And then now there's all these incentives, right? It actually saves a lot of money. And so now policymakers care about it too, which is a good thing for us to also identify. So with that, I'm going to turn it over to my colleague. And let's see, I'm going to stop sharing. But yeah, I'm not sure if you wanted to do questions now or if you wanted to wait.
Melissa, we're going to hold questions until the end. And we really appreciate that Tiffany has done a lot of home care. So you really know in your experience the practical importance of everything Melissa presented. So you're going to help us understand better how we can start thinking the capable way, right?
Exactly, Martha. I'm going to be providing you all with some important tools and concepts that are all publicly available. So I'm going to go ahead and share my screen. Okay. All right. Is that visible to everyone?
Yes.
Okay. So my name is Tiffany Reiser, and I'm going to be speaking with you about implementing the concepts of capable related to fall prevention and also related to self-advocacy. So here in the United States, 1 in 3 people over the age of 65 fall, but fewer than half ever talk with their provider about it. So my talk will primarily focus on the use of, as I said, publicly available tools, primarily the CDC's STEADY initiative, because it includes a large amount of online information related to fall prevention and home safety. STEADY stands for Stopping Elderly Accidents, Deaths, and Injuries. It will cover, I will cover a few of the tools from this initiative, including the fall prevention checklist and the fall prevention medication review. I will also cover a self-advocacy tool used by Capable. And here's a screenshot and link for the CDC STEADY main page. So this is a diagram of the key steps in coordinating and implementing fall prevention programs in the outpatient setting, but it can also be applied to community settings And these same steps can be applied to other interventions, not just fall prevention. Each step is an important component of the process, but they are not always completed in this exact order. Implementation and evaluation can often go back and forth between steps, and you may find yourself revisiting earlier steps based on new information, and that's okay. For example, a group might describe their program before having a chance to engage with stakeholders, and then they may revise the program description based on stakeholder feedback. Some steps I would like to highlight are what we call pre-implementation activities. These include assessing the organization's readiness for change, assessing the organization's current fall prevention practices and activities, and this also includes identifying key stakeholders. The assessment that takes place before the active implementation of an intervention may include focus groups, site visits, observations, and interviews. Important implementation concepts to think about are the concepts of utility and feasibility of the program. So this means, is the program useful and does it serve the needs of the population? And also this means asking yourself, is the program realistic and reasonable for the setting and for the available resources? Successful fall prevention programs should involve a variety of stakeholders who have different perceptions in order to set goals and objectives that are truly relevant. This is important because it informs how you define the success of a program, how you adapt the program to your setting, and how you develop a plan to actually evaluate it. So now I'm going to talk about a specific tool called the Stay Independent Questionnaire. It is made up of 12 questions that older adults or caregivers can ask themselves to assess their level of risk for falls. I will highlight some of the questions from this tool, but for the full questionnaire, you need to see the CDC's online resources, which we will provide to all the audience after today's talk. It is important that you assess multiple risk factors to help identify those at increased risk for falls. This will help you to identify those who are most poised to be targeted for an intervention. One could ask whether the person has had a fall in the past year. You can ask whether they have been advised to use an assistive device like a walker or a cane. You can ask whether they feel unsteady or do they use furniture to balance when they walk. You can also ask whether they have a fear or worry of falling. Or also asking about lower extremity neuropathy. And asking whether they are taking any medications that cause side effects like dizziness or lightheadedness. So here I'm going to highlight some items from the CDC's Fall Prevention Checklist. Again, for the entire tool, please visit the CDC website resources that will provide. So this checklist can be used by older adults or caregivers to conduct a self-assessment of the safety in their own home. This tool can help to identify problem areas in the home that may be in need of some form of modification. For example, are the handrails loose or broken? Or is there a handrail on both sides of your stairs? Do you have throw rugs on the floor that could obstruct your pathway or cause a trip or fall hazard? Are there things that you use often in your kitchen on high shelves or high above your head, or are they located within easy arm's reach? Is the path from your bed to the bathroom dark, or is it well lit? And also, do you need support when you get in and out of the tub or on and off the toilet? These are all important questions that patients and caregivers can use to assess their own home for safety. So here I'm going to talk about a tool and describe something called a medication review framework. It is called SAFE, and SAFE stands for screen, assess, formulate, and educate. This framework can be used to develop tools that address fall risk medications for older adults. So for the S, you want to screen for medications that may increase risk. You also want to assess the patient for the management of their chronic and acute health conditions. You want to formulate a medication action plan and provide education about medication changes and fall prevention strategies. Here's an example of a fall risk medication action plan. It is meant to be used by patients and caregivers. It encourages them to ask their provider specific questions, write down answers to those questions, and write down action steps that they themselves can take. The personal action plan is an example of a self-advocacy tool. Self-advocacy is the ability to communicate your needs, and self-efficacy is confidence in your ability to control your motivations, your behaviors, your performance, and your social environment. The health passport is a tool that can be used for self-advocacy and to promote self-efficacy. The health passport organizes clients' health information and promotes communication between healthcare providers. Older adults or caregivers can carry their health passport with them to all of their medical appointments and update the passport when there are changes in their health information. This includes keeping a pain record, a vital signs log, an incontinence record, documenting changes in medications or the current medications that you're taking. This passport can also include writing down questions or concerns that you want to make sure that you ask your providers the next time you see them. And lastly, I will talk with you about the key drivers or key elements of age-friendly care. This framework was developed by the Institute for Healthcare Improvement. The 4 elements are mobility, mentation, medication, and what matters. The Capable program meets all 4 of these elements. A specific driver that is important not to exclude when you are developing age-friendly programs is the what matters. Personal values are important motivators for behavior, and older adults are no different. Interventions should be aligned with the patient's health goals and preferences. To promote self-efficacy and to actually reduce disability for older adults, the Capable program effectively prioritizes the patient's goals and the patient's values. So here I've included a list of resources used for this presentation, and I would like to thank you very much for your time and for your attention. Thanks.
Thank you, Tiffany. And we'll make sure that all of those resources are available with the appropriate link for everyone.
Thank you so much, Martha.
Thank you. And we now go to Sabrina. And Sabrina, welcome back to PAHO. It's not, as you know, it's not always easy to work with our healthcare providers. Very few of us have access to a geriatrician who really focuses on function and on shared decision-making. So in your experience, how can we expand, our healthcare team so that we are really more capable of maintaining function, getting good health care, and become experts in our own healthy aging? Because unless we do that, it's going to be very difficult. We're not all have the privilege of a geriatric team. And therefore we have to almost become ourselves empowered to be our own our own advocates. So I'm looking forward to what you have to say, Sabrina.
Thank you, Martha. And I'm going to share my slides now. Can you see?
Mm-hmm.
Yes. Great. So good morning, buenos dias, bom dia. As it was mentioned, my name is Sabrina Elias, and I would like to start thanking the Age and Health Program of the Pan American Health Organization, and also the Retiree Association for hosting this event, and of course to Dr. Ladek and Marta Pelais and Patricia from PAHO that made all this possible today. So, and I'm also would like to greet my former PAHO colleagues that are here today. So hi everyone, it's nice to be back. And I'm very excited to have this talk with you today, so let's get to it. So the objectives of my presentation today, we're gonna talk just briefly about healthcare delivery approaches. And then we're gonna share about this concept called shared decision-making. And then we're gonna talk about how to engage in shared decision-making. And also I'm gonna share with you some resources for you to actually make this possible for you. And as we saw in the previous presentations, Capable is a person-directed program. So everything revolves around the goals of the individual that is going through the program. And we can see that voicing our needs, our opinions, and our goals, it's very important. And it's important in all aspects of our life. And it's most important when it comes to our health and well-being. So throughout my talk, we will discuss an approach that can give us guidance on how to actively engage in our healthcare. And this is what we're gonna talk about in the next slides. So before we start the bullet points and more specific information, I would like for us to think about a situation. Okay, so if you need to close your eyes or if you need just to concentrate, imagine that you are at your healthcare provider's office. Okay, you just went there for a checkup. You know, you don't really feel anything different. But then, based on the things that they are noticing in your blood pressure and different things that you bring about in that appointment, they realize you have hypertension. And then the provider gives you a prescription, asks if you have any questions, and then greets you as you leave the office. Who haven't been in such situations, right? And then you go back home. Hypertension, I think that's the same as high blood pressure, but could be because of stress. I don't feel anything. But anyways, let me go and pick up my prescription and start this treatment. And then, unfortunately, you started having some weird symptoms, things that are unusual, and you think, well, I didn't have this before, and I started in this new medication. Maybe this is actually doing more harm than good. So you know what? I'm going to stop with this. And of course, we are busy. We are taking care of our loved ones. We are finding new interests, working on different projects. So, you know, that follow-up visit gets postponed, delayed over time. And then unfortunately, in a few years, you have a stroke. And we are discussing a scenario that is not real, but unfortunately, this is the reality for a lot of people dealing with various health problems. And according to the CDC, 6 in 10 adults have a chronic disease in the US. And our countries in Latin America, we have similar data. And chronic diseases is a problem globally. And then 4 in 10 adults have even 2 or more of these chronic diseases. So we can see that that scenario we just talked about, it's actually happening for a lot of people. And then these chronic diseases, they're leading to death, to disabilities, and they're drivers of this annual expense of $4.1 trillion per year. So it's a lot. And as we saw with the Capable program, there are options of things that we can actually do to improve some of these bad outcomes. Okay, so I talked with you about the situation and a stroke and all these chronic diseases. So, but what can be done? Let's talk about solutions and things we can do to change the situation. So US legislation, for example, the Affordable Care Act, and many leading organizations, they endorse an approach which we talked about when I talked about the goals, which is shared decision-making. And some of these organizations are, for example, the Agency for Healthcare Research and Quality, the National Quality Forum, the American Medical Association, Mayo Clinic. So we see that there are very impactful organizations and legislation that is pointing us to the direction of let's do shared decision-making. It will help you when you are interacting with your provider. Okay, but if we are thinking about a new approach, what has been done and why it's not working? So this is when we start talking about healthcare delivery approaches. And here you can see a clinician and then an individual, and then we have the modules in the middle. So if you see this, the paternalistic, the arrow is going just one direction, which means that the provider gives information and recommendations, but they're also the one that makes the decisions for the patients based on what they think are the best interests of the patient. And then we have informed medical decision-making, which the clinician gives information, obtains a consent, but again, there's not much of that dialogue between the two. So what is then this shared decision-making? The shared decision-making is when the clinicians and the patients, they make the decision together, and how they do that. So the clinician will share what are the treatment options based on evidence, right? Scientific evidence. We can do A, B, or C. A might work better for these issues, B for those issues, and C for other problems. And then the patients, like we saw, how can an individual wash their own hair if the medication they take during that time, it's the medication that will make them dizzy, right? So if the patient doesn't communicate to the provider and the provider doesn't ask the patient about their goals, their values, their preferences, none of this is looked at, right? And in Capable, there is a program that is being implemented for individuals and help them think through these issues. But we don't need to wait to be an individual participating in this program to take the power on our hands and make things different. So this is what we would like to do with shared decision-making. And of course, there are training and a lot of information online about how providers can get ready for shared decision-making. But I would like to share with you today how individuals, how we can take this in our hands and make it happen. Okay, so before we go on to that part, I just want to finish talking about the healthcare delivery approaches. So as you can see here, the individual is in the center, and then everything it's done with the patient in the center. And the reason I put this image here is because shared decision-making is considered one of the main features of patient-centered care. And then it improves health outcomes, is a possible strategy for this. And of course, when we are working together with our providers, when our values are taken in consideration, we have best quality of care quality of care is improved. And those organizations that I shared with you before, they are behind the fact that when you have more shared decisions, there is a higher achievement of quality in healthcare. So this is something that is important. And then results of different studies also show that shared decision-making is associated with shorter hospitalizations and also less invasive treatments and also lower medical costs. And it also increases the use of, for example, preventive care. It helps improve the patient and provider interaction. It helps with adherence to treatment, with health literacy, with patient satisfaction. So there are a lot of good things that come out of shared decision-making. And then we also have better health outcomes across several diseases, such as, for example, improvement in diabetes, in high cholesterol, disease control, such as like following health eating plan, monitoring your own diabetes, among others, right? And now I want to talk, now that we talked about the shared decision-making, how can we do this, right? Because it's nice, we saw the results, we saw the different impacts, but how can we? So change is beautiful, as we see here, but it takes time, right? And it will take a while for our health systems to adapt, to make the necessary modifications, to train providers. So it will take a while to come from that end towards us. But we can start today and make it come from our end towards the system. And this is what I would like to share with you today. So we can be proactive and we can benefit from this now. So what we should do? So the first thing is to learn about shared decision-making and what it is. And I will give some of this information for learning about shared decision-making today. And it's important that you take this information and you don't keep it to yourself. Talk with your friends, talk with your family, talk with your provider about this. Oh, I learned about this shared decision-making. Have you heard about it? Like, have you used this? And this will help you grow stronger on your knowledge and also help others in their own path, right? And then, spoiler alert, our discussion today is already helping you with all of that. So let's keep going through it. So it's important that we work on our communication skills and also our ability to claim space. And what does that mean? Given what we saw about the healthcare delivery approaches, it's very common that it's like a natural hierarchy that happens between providers and individuals. And that's based on intrinsic bias, things that we grow up believing, things from our culture and our society that already puts these dynamics in place. But there's something that can really help us shift this dynamic around and make the field like it's equal for both parts. And that is, hello, I'm an expert. Each one of us, we are an expert on our own health, our own body. We know our body like no one else. You know things that make you feel weird. You know things that make you feel good. You know the things that are important to you. You know you want to take a shower in your own bathroom and using our own things without help. So we are our own experts. So when we have that in mind, that in itself already help us think, okay, I'm an expert, so I can voice my opinion, I can ask questions, I can communicate and claim space during this interaction. I had patients in my PhD dissertation at Hopkins that they told me, it helps me when I talk with the provider and they listen. And I had another patient say, and I told her, what strategies do you use for the providers? Like, what helps you when you are making these decisions together? And she says, well, I go on there and I make sure they listen. If they have someone next, they say, well, I'm the one here now, so let's talk about the things that I need to ask you, right? And I know that can be difficult. Even when you are a healthcare provider, when you are in the field, you feel those hierarchy dynamics, and you might feel like, oh, you know, but they're the expert, they know better, they know the disease, they know the treatment, I don't know much. You do, you are an expert, put your voice and make yourself be heard. And then something else that can help us with that process is called health literacy. And health literacy, you can become health literate when you know your medical history, you ask questions to your providers, you access resources that help you learn about your disease and different treatments. And in this aspect, it's very important that we try to look for information in trustworthy websites. And we know there's so much information on the internet. And we saw, especially with COVID, how misinformation can really get on the way of us keeping everybody healthy and in our well-being and everything. So generally, websites that have, for example, .edu, .org, most likely information from those resources, they are more trustworthy than you go to a more commercial page, or if you go to your social media, or if you go to your social media groups. So this is something important when you're looking for information about your health, because we want to get the best information possible. And then it's also nice to have a blueprint. So a blueprint is something that tells you, oh, let's follow these steps to achieve whatever outcome you're trying to achieve. So my next few slides, I wanted to share with you a blueprint for you to self-implement shared decision-making and help your provider get on board with you. So these are some of the key components of shared decision-making, but from the provider's perspective. So providers should be aware about creating choice awareness, tailor information, patient's preference, learning about the patient, describing treatment options, deliberate, and then making a decision. But like I said, this comes from the providers, and our health system, our primary care provider, they might not be on board with this yet. So I'm going to talk about, for each one of these, what can we do to achieve this? So first of all, you can ask if there are options to be considered, right? If the provider tells you, oh, this is the treatment, let's start this, and you can say, well, are there other options that we consider regarding this? Other treatments, other medications, what is out there? And then another one is to ask for individualized information. Maybe they're talking about something more general, but maybe that's not applicable to your racial group or to your hometown, or something related with people that have comorbidities like you. So you can ask for individualized information, and you can also ask, could you please talk in using terminologies that I can understand? Because providers, we are so used to charting and talk with each other using specific terminology. We might forget to talk with the patient, you might forget about that. But if you are active, you think I'm an expert, I can claim my space and I can ask for the language that is being used to be one that I can understand. And then you can communicate your goals, your concerns, your preferences. You don't need to wait the provider to ask you this. You can go on and say, okay, it's important that I'm not dizzy because I take care of my children. It's important that I go out and I like to walk as my exercise. So I need this medication to be prescribed in a different time or less times a day. We need to put our voice out there. And then we can check if the provider actually understood the communication we are sharing with them, right? Maybe we say something, somebody else say something else, so you can make sure that they are on the same page as you. And then you can ask for a description of the treatment options. It's important that they give you these options after you have shared your preferences and values, because if they just give you options, random options, without learning what is important to you, those options will be specific to the things you need. So it's important that those informations are exchanged between the two, and then options based on that, not just the evidence of what is good, but also what is important for the patients, their preferences, and then based on the sharing of those things, then we talk about options based on those. And then, of course, we can negotiate, we can deliberate, and then we can actually make a decision, or we can decide to defer the decision for a follow-up appointment. Sometimes it's important for us to discuss things with our loved ones, or maybe we want to read more about something and we don't want to make the decision right there and then, and you don't have to. You are the ultimate authority over your decision. You can decide to postpone it to a follow-up appointment. And then based on whatever it is that was decided, you can arrange a follow-up or discuss the implementation of the option that was selected. So now, before I end my presentation, I would just like to share some resources. So the first one, the key components, is the things that we just talked about, that blueprint on things that we should keep in mind when we are interacting with our providers. We can also use something that is called patient decision aids. Patient decision aids are tools that we can use that are specific to our situation. So, for example, somebody is making a decision between a treatment A and a treatment B, but they don't know much about the disease, they don't know much about the options. So these patient decision aids, they can be written, audiovisual, or online tools. They give a presentation of the health condition, and then they give options of tests for that or treatment. And then it also gives you the benefits and harms of each, so that you can have a very informed decision. And then there is a decision coach. This decision coach is a health professional that helps individuals to prepare for making a decision. And they are like trained in how to do this, or they can use like a protocol on how to help patients through this. The patient decision aids, I'm going to share some resources where you can access a directory of this. For the decision coach, you can ask your provider if they have this available in their setting. And if they don't, you can ask, could someone from the health team help me go through this decision, review the information, and if they would like, you can share with them, oh, there is a protocol for this. I can share the resource with you, and then we go through it together. So these are the resources. The Ottawa Hospital Research Institute is part of the University of Ottawa in Canada, and they are really big on research on shared decision-making, and they have many, many patient decision aids for all types of health conditions. And there is also a resource from the Mayo Clinic. They also have many patient decision aids that can be used. And then the Agency for Health Care Research and Quality, they have a resource about patient engagement and education. So these are the links, and these will be shared in follow-up communications. So I would like to thank you for participating with us today. And the three of us, we are very happy to connect with you and continue this conversation. So you see our contact information here on the page. Thank you everyone for listening. And now I think we'll start the question and answer, right?
Yes, thank you very much, Sabrina. You've actually shared a lot of great information. I could not help but hear in the back of my mind, that voice that said, how do I do it? How do I do this in a 3-minute patient doctor's visit? How do I really do all of this in those situations? And I think what you have shared with us is not only an ideal situation, but also the situation that we should all be working towards. And if I have learned anything in my life, is that there is such a thing as really the power of organized advocacy. As older adults, we really need to organize ourselves and say, healthcare system, primary care doctors, health clinics, you really need to listen to us. You really need to give us what we need. And that is really part of a revolutionary movement that has to be created. And I'm sure that when Patricia talks about the decade of healthy aging, and one of the areas of work in the decade of healthy aging is to have an integrated healthcare system that really addresses the needs of older people. What you're giving us is a lot of really good information that may not be, as you say, there yet. And I would say that in probably 99.9% of health clinics is not there. That very few private healthcare providers are there yet. Some are. Geriatricians are there. Most geriatricians, not all, most geriatricians are there, but they're far and few between. So what I think you've given Melissa, Tiffany, and Sabrina, what you have all given us is a really great, you have inspired, I hope, many of us to think about how we can contribute to better access to appropriate health care and how we're going to get that done during the decade of healthy aging. Because if we don't get that done, the decade will remain, a nice thing that was done, but not really something that truly changed the lives of older people. So how do we really become activated personally in our own relationship with our physicians, but how do we also become activated with the healthcare providers and the system that is offering healthcare to most older people in our communities? So there's a lot to think about. And we now have a few minutes I want to give Patricia Morse some time to talk about the decade, but I want to allow, I know that, and I am so thankful for all of the, for everyone of all of you who, the presenters who have been actually providing responses to many of the questions as they were asked. I don't think there are many open questions. So what I have seen is, the one question that I have is for Melissa. The last question that I got, Melissa, how is the handyman or the handy worker trained to be part of the team? How do you choose? Does it take an actual training for a handy worker to become part of the team, or how does that happen?
That's a really, really great question, because, there's different levels of equipment, right? So if, for example, we're trying to make a bathroom safer, in the example of this person wants to be able to wash their own hair, which means getting in and out of the bathtub, probably some hand grips, right? There's ones you can buy at the store that are suction cup, which over time, the suction actually wears down and actually creates a fall hazard. So having the correct equipment installed and installed correctly is a really important part. And also that's something that families, we can do for our loved ones too, is in order to make homes safer and keep people in their homes. But yes, there is training. So Capable usually will partner with an organization that provides handy workers. And so, for example, in the Baltimore area, which is where Capable was originally tested. And by the way, I didn't talk as much about the participants. They were all already disabled and they were all financially limited. So this was already a group of patients that were very high risk for nursing homes, high risk for hospitalizations. So yeah, the handy workers were all trained and they were a part of this organization called Civic Works. And it was an organization that had trained handy workers as a part of it. So I think your question is finding the right partners is really important, whether it's with an intervention like this or even as a family member, right? Hiring a licensed handy worker, I think, is a good start. Someone who knows how to install a grab bar in the shower correctly is an important piece. I'd say a great way to do that sometimes also is going to be word of mouth too. If you are at someone's house and they have a great grab bar that is appropriate, then certainly that might be a good indicator to get that person in.
Thank you, Melissa. There is one other question that has been coming up, and that is there a definition of for personal assistant? In other words, sometimes in a person's home, you need, in addition to modifications, you may need a personal assistant. Is that personal assistant also part of the team, and is there some resources to learn about the criteria for hiring that personal assistant or job description for that personal assistant?
That's a really great question. So yeah, the personal assistant, or I think the home health aide or the certified nurse assistant, those are all terms used in the US for, help. There's also informal help, right? There's the caregiver, there's the family members, the informal caregivers, which I know I'm an informal caregiver. I know a lot of us are. That wasn't a part of the Capable team. And the one thing that I would say as far as inclusion, exclusion criteria for this group of people that this was originally tested on, since then it's been used in many different settings, but people, if someone was hospitalized overnight, like admitted, not the emergency room only, more than 3 times in a year, then they were excluded from the original study. And the reason was because we wanted to have the 4 months to be able to work with them. And so I think that is an important piece to mention, that this group was probably could use the nursing aid support or the home health support, but for the most part, most of this group couldn't afford it. This is not a group that it could afford to pay for that. This group was all very financially limited.
Thank you, Melissa. So there are a few other questions, and I think we will actually share with you some of the answers. The one that I think I like to refer to all of you, that Melissa and also Patricia, is how can we propose this program for our city, wherever it is? How can we actually say, try it, let's do a pilot, let's actually try to see how this works. and we don't have time to go into the details of that process, but I think we really need to move forward and ask Patricia Morsch now to not only conclude, but with that in mind, also address how PAHO is working with communities to really work in all of the areas of the decade. So Patricia, and I'm sorry for those of you who still have questions that we need to really honor the time at this point. Patricia.
Thank you very much, Martha. And first of all, thank you everybody who joined us today for this webinar, and especially Melissa, Sabrina, and Tiffany. It was great to hear from you and all the information that you had that you shared with us about aging at home, the prevention of falls, and very important, the person-centered care, and how important is having functionality in mind and being able to function well while we are aging, and not only controlling diseases. This is very important too, but like having in mind what matters for older people, and of course being able to stay at home and in their communities. I also want to thank Martha, Gloria, and all the association of former staff members of PAHO WHO for organizing this third event in collaboration with our Healthy Aging team, and for being so active and eager to promote healthy aging with their peers. I think concerning what Martha said and about the decade of healthy aging, it's very, very important, and the Capable program is being emphasized by our Healthy Aging program. We recently published a portfolio of evidence-based community interventions that can support older adults' capacity at the first level of care, and Capable is one of the programs that is listed in this portfolio. As the link to this document will be shared in the chat. And this is, we are trying to promote these programs because there is an opportunity to bring to older adults closer to where they live and in the community strategies that can improve or maintain their functionality in an easier way to access than its other levels of care. So as Martha said, sometimes it's difficult, the implementation of the programs, but sometimes we have to find the right partners to start with a pilot. To sometimes it's universities, sometimes it's centers like community centers. And one important thing that Melissa showed in her presentation is the effect of these programs. So I think one way that we can start these implementations and we can move forward with these types of strategies is showing how they are important, of course, but their effect, not of course for individuals on their own health, but for their families as well, and for the health systems. Because as Melissa showed very clearly, how it improved individuals' health, but of course it saved money for the systems. So this would be a step that we can look forward to implementation. Also, I think it's very important, and then I'm going to bring this to the Decade of Healthy Aging, or the United Nations Decade of Healthy Aging, that it's our main framework of work right now. We have to be able to talk and to bring this knowledge and to highlight the importance of this work on like what is healthy aging, what matters to older adults, and what we have to do to achieve that. So the Decade of Healthy Aging have 4 main areas of actions that will open the floor to work towards healthy aging, that is maintaining older adults' quality of life, functionality, and not only for them, but for their families and the communities where they are. And the first one is the combating all the ways of ageism. So all the prejudice and the way we think, act about aging and age. Also, the environments, having friendly environments that support older adults' capacities. This is very important, as it was highlighted in the presentations, to prevent falls, to make friendly environments that older adults would be able to function well and at home or in private and public places. As Marta mentioned, another area of action, the integrated care. And then Sabrina made very clear on her presentation the importance of like how about myself and my needs and my situation. I am the expert. And I have to be able to communicate that well with my provider. And of course, this would enable or will favor a person-centered care. And it's very important that we are activated, as Marta said, and work towards supporting this person-centered care with our own self-care and self-management. And the last one, area of action of the Decade of Healthy Aging concerns long-term care. And this is also very important when we think about older adults that live at home and depend on somebody else, as it was already discussed right now in the questions and answers, and having someone, a personal assistant or a caregiver. So we have a lot of work, but we have already great partners working with us around the Decade of Healthy Aging, and we invite everybody to be part of it and to join in the activities that we are proposing around these areas of actions and healthy aging. So I would like to invite you all to know our website. There is a lot of information on healthy aging and on the Decade of Healthy Aging. Also to subscribe our newsletter so you can get to know what's going on, the events that we are planning, the activities, and also engage on the Decade of Healthy Aging platform. It's a virtual space where you can share knowledge, share your own histories if you are like an older person, and you can connect with other people that are working or have similar interests as you. So all these links are available on the chat right now. And I would like to invite you all to our next virtual event that will be the launch of a series of publications about the situation of aging and health in the Americas. And all these documents, we will have approximately 15 documents published in English, Spanish, and Portuguese. And they will be in a host platform, and in this platform there will be a space also for engaging and suggesting topics that we need to address and to update in the next documents that are going to be published. So I hope I can see you all at this event as well, and the link to register is in the chat. And again, I would like to thank you, everybody that is here, especially the presenters, and of course AFSM for the great work on healthy aging. Thank you very much.
Thank you. And we really appreciate, we have a minute, and I know that Gloria had her hand up at one point. So Gloria, do you have a last word for the group?
It's been a marvelous hour and a half. Hard to imagine anything better than this. How do we get it out to the older population? I would suggest working with the media, with journalists. This information really needs to be sent out on the popular media. And I'm thinking of the presentations that each of you made and how important that would be for the general public, for those of us that are older than 65. I read an article recently, what was it, 100 is the new 80. So we have a few more years ahead of us. And this information really needs to get out. Melissa, I don't know if Johns Hopkins has a journalism program, but it seems to me that that would be a key link. You do have good journalists at PAHO, so perhaps that's something we could explore. Thanks again. It's been a wonderful hour and a half.
Thank you, Gloria, for that. Those last words are golden words because we can talk to ourselves, but we really need to change the environment in which we live and work, and we need to have the media on our side, and we probably don't have it at this point everywhere we want. So let's build bridges with media, and Gloria, you're the expert in that area, so we'll continue to look at you for ways to improve with that. So thank you. We are a minute over time, and I just want to thank everyone who stayed until the end with us, and we'll especially thank our panelists. And I just have to say, Melissa, Sabrina, and Tiffany, you're all part of our family now, and we'll continue to call on you as our favorite experts. So thank you, and goodbye.
Thank you all. Goodbye.
Thank you for the opportunity.
Thank you so much for having me. Bye, everyone.
Yes, thank you. I appreciated being back.